Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. We continue our lecture about genital tract infection, and this is the second type of infection, which is upper genital tract infection. Infections of the upper genital tract consist mainly of pelvic inflammatory diseases. What are pelvic inflammatory diseases? It's caused by microorganisms colonizing the endocervix and ascending to the endometrium and fallopian tubes. So it is of clinical diagnosis, implying that the patient has upper genital tract infection. The inflammation may be present at any point along a continuum that includes endometritis, salpingitis, tubo-ovarian abscess, or peritonitis. The patient can come with pain, adnexal tenderness, fever, and vaginal discharge. The causative agents for pelvic inflammatory diseases are most of them are the organisms that are sexually transmitted, like TB, syphilis, Neisseria gonorrhea, or Chlamydia trachomonas. But also there are other organisms like polymicrobial Staphylococcus, Streptococcus, or Clostridium perfringens. Infection begins in the cervix and vestibule, then descend to the tubes and ovaries. What are the risk factors for pelvic inflammatory diseases and sexual transmitted diseases? Multiple partners, pregnancies before the age of 20, that's to say the patient is sexually active in very young age. Age group between 15 and 34, this is the same point. Previous termination of pregnancies, previous sexual transmitted diseases, abnormal cervical cytology, and prostitution. So that's why sexual history should include the following important things like time since last intercourse, the type of intercourse, contraception, type of contraception, number of previous partners, menstrual history, previous pregnancies, previous treatment for sexual transmitted diseases, and the history of drug use for the same patient and her partner. What will we do for lab diagnosis? We will take CBC. We see that T cell lymphocytes will raise. That's to say leukocytosis, shift to the left. Sometimes the opposite, you may find decrease in white BCs. CRBC, reactive protein, and DSR will be elevated. Vaginal wet smear will show large amount of white BCs, highly suggestive for upper genital tract infection. When you do transvaginal ultrasonography, you will see one of these findings, maybe tortuous swollen fallopian tubes, and most commonly you will see free fluid in the pouch of Douglas. Laparoscopy is the gold standard for diagnosis of pelvic inflammatory diseases. The spectrum of lesions are as follows: endometritis, acute suppurative salpingitis, salpingo-oophorytis, that's to say the infection of tubes and ovaries, tubo-ovarian abscess, the same thing that, with accumulation of pus between the tubes and ovaries, biosalvix, the accumulation of pus, hydrosalpinx, accumulation of fluid, or chronic salpingitis. This picture shows you the different types of infections as we mentioned in the previous slide. We take the salpingitis, that's to say the infection of the ovarian tubes. Clinical findings are acute onset. Patient come with lower abdominal or pelvic pain, usually bilateral, because the infection ascending from down up, and it will involve both tubes oftenly. In most cases, symptoms appear shortly after mens, during mens, or after mens. Purulent vaginal discharge, that's to say ulcering in the vaginal, normal vaginal discharge. Nausea, sometimes vomiting, because the temperature will be elevated more than 38 degrees centigrade. lower abdominal tenderness on examination, and on bimanual examination, there will be tenderness in the cervix, which is referred up to the uterus, which is called rebound tenderness. Laboratory findings, as we said, will be increase in the YTBCs. Smear of vaginal discharge will demonstrate diplococci. Endocervical smear, we take it for culture and sensitivity, and we do ultrasound, and mostly, and the most important one is transvaginal ultrasound to see the fluid in the pouch of Douglas or inflammatory mass. If we cannot put diagnosis by these examinations, we can do laparoscopy, which is the visually confirming our diagnosis. What are the differential diagnoses? This is very important. You must keep in your mind many things that give a similar picture to the pelvic inflammatory disease, to the salpingitis. For example, acute appendicitis, which is common also, ectopic pregnancy, ruptured ovarian cyst, infected septic abortion, torsion of adnexial mass, fibroid, which is called neomiom, endometriosis, UTI as simple as, or other GIT problems like diverticulitis or enteritis. The complications that you suspect to see from salpingitis are peritonitis, pelvic thrombophlebitis, formation of pelvic abscess, and in the future, of course, infertility, ectopic possibility of ectopic pregnancy, chronic infection, adhesion, sepsis, etc. So this is very important subject, especially in the infertility units. The second one is endometritis. The patient come also with lower abdominal pain, fever, shivering, purulent vaginal discharge. Maybe if you take history in details, you can take history of termination of pregnancy or intrauterine procedure in the last period, or using of intrauterine contraceptive device. She will complain of lower abdominal pain, and on examination there will be lower abdominal tenderness. PV examination will reveal large tender uterus and rebound tenderness, as we said before. Lab finding similar to that in salpingitis, and ultrasonography you will see reveal picture of endometritis. Treatment of this, either you see the patient is not so sick that you can treat her as outpatient treatment, so you can choose one of these regimes. Either regime 1 is cephalosporin plus doxycycline for 14 days, or regime B is also cephalosporin but another types, with flagyl 14 days. If you see that the patient is very sick, or she has one of these criteria, the following criteria, so you must keep her inpatient, that's to say hospitalization, case of suspected pelvic or tubo-ovarian abscess, pregnancy, the temperature is more than 38, inability to tolerate per oral intake, peritoneal signs, that's to say acute abdomen, peritonitis, failure to respond to oral antibiotics within 48 hours. If the patient is very young, that's to say adolescent patient, nulliparous patient, or if your diagnosis is uncertain 100%. As inpatient, you will treat her with cephalosporin also, but high dose and intravenously, and every 6 hours or every 12 hours, depending on the type of cephalosporin, plus doxycycline 2 times daily, plus flagyl metronidazole to cover the anaerobic organisms. If she is not tolerating cephalosporin or allergic to cephalosporin, you can choose clindamycin plus gentamicin. And in this case, you don't need to use flagyl because clindamycin will cover the anaerobic microorganisms. What are the complications of pelvic inflammatory diseases? Acute complications like peritonitis, bacteremia, endocarditis, meningitis, or suppurative arthritis. The patient, keep in your mind, the patient can come with one of these symptoms first. So not come with symptoms of pelvic inflammatory diseases, come with complication first, like arthritis, for example. Or chronic complications, come with chronic complications like infertility, tubal obstruction, ectopic pregnancy, pelvic pain, or intestinal obstruction because of bowel and pelvic organs, adhesions, what's called frozen pelvis. So again, keep in your mind the differential diagnosis of pelvic inflammatory diseases, as we mentioned before, from appendicitis to less commonly one, which is adnexial tumors. Here, picture of complication of pelvic inflammatory diseases, severe pelvic inflammatory diseases, especially gonorrhea and chlamydia, which is called Fitz-Hugh-Curtis syndrome, which is perihepatitis. These adhesions, strengths of adhesions between the liver capsule and peritoneal tissue. Now we will speak about sexual transmitted diseases. What are the sexual transmitted diseases? They are disorders that spread principally by intimate contact, and many sexual transmitted diseases can be acquired by transplacental spread or perinatally, that's to say during labor. And most of sexual transmitted diseases are actually all of them are the precursors for pelvic inflammatory diseases. Classification of sexual transmitted diseases, either according to formation of genital ulcer, for example, herpes simplex virus, syphilis, chancroid, granuloma inguinale, or without ulcer, like Trichomonas vaginitis, for example, or according to the etiology, either bacterial, for example, gonorrhea, syphilis, Mycoplasma homonis, Chlamydia, viral infection like genital herpes, human papillomavirus, HIV, cytomegalovirus, or protozoal. And the only protozoal sexual transmitted disease is Trichomonas vaginitis. Here, this schedule showing to you, it's very nice, showing to you the types of organisms, which type of organism, and the disease caused by this organism, and what are the diagnostic features. For example, gram-negative organisms like Gardnerella vaginalis, which is the most common one of bacterial vaginosis, and Haemophilus ducreyi. This is the important sexual transmitted disease cause chancroid, soft chancre, and Neisseria gonorrhea. Also, it is important sexual transmitted disease that cause gonorrhea. In spirochetes, we have Treponema pallidum, which causes the syphilis. In mycoplasma, we have Mycoplasma homonis and Ureaplasma ureolyticum. These are important organisms that cause non-specific vaginitis, and they are hidden and can cause rupture of amniotic membrane and premature rupture of membrane in pregnant female and premature labor. It's very important. Rickettsia, we have chlamydia. Chlamydia, there are many serotypes. We will speak about them later. They cause pelvic inflammatory diseases. Viruses, we have human papillomavirus, different types from low risk to high risk. And we have cytomegalovirus and molluscum contagiosum. From Mycobacterium, we have Mycobacterium tuberculosis. And from fungi, we have Candida albicans, the most famous one that causes candidiasis and the infection of the with abnormal discharge of the lower genital tract. Now we will take syphilis. We will continue our sexual transmitted disease and take syphilis. All women with genital ulcer should undergo a serologic test for syphilis. Syphilis caused by Treponema pallidum, which is a tribanomal infection with both sexual and vertical transmission. The incubation period can be up to 3 months. Presentations according to the stage, either primary syphilis, usually present 3 to 6 weeks after infection, with the chancre, which is painless genital ulceration, and inguinal lymphadenopathy. The most common site of chancre in women is cervix, and therefore it's sometimes asymptomatic. The primary infection will resolve after a few weeks if untreated. If the infection continue, we will see the secondary syphilis may arise immediately after the primary disease or up to 6 months later. The signs include rash, fever, joint pain, condylomata lata, which is wart-like lesions. Iritis and hepatitis may occur also in this stage. Diagnosis: the organism can be identified in exudate obtained from the primary lesion mixed with saline by forming dark field microscopical examination. The most sensitive serological test is a fluorescent tribonomal antibody test, which is called FTA test. In a primary disease, the serology may be negative. If you diagnose syphilis primary or secondary stage, the treatment will be penicillin. Penicillin is the drug of choice. Either brocaine penicillin, here the dose of brocaine penicillin 1.2 million units for 12 days is the treatment of choice, or you can use benzathine penicillin, double this dose, 2.4 million unit, which you can repeat after 1 week. Doxycycline, erythromycin can be used also. Contact tracing need to involve a partner. After syphilis, we take chancroid. Chancroid is the next most common cause of sexually transmitted diseases and ulcers that cause ulcer. Etiology is Haemophilus ducrei. The incubation period is 3 to 5 days. Increased rate of HIV infection has been reported in patients with chancroid. The clinical findings are painful, tender ulceration, vagina, cervix, anywhere in the genital area. The lesion produces heavy foul discharge that is contiguous. Painful inguinal adenitis with erythema influence 50% of cases. For lab diagnosis, we must exclude syphilis. So we must test for syphilis also. Clinical diagnosis is more reliable than smears or culture because there is difficulty in isolating this type of microorganism. Treatment, you have 4 regimes. You can use one of them: azithromycin, ceftriaxone, ciprofloxacin, or erythromycin. Patients should be re-examined 3 to 7 days after initiation of therapy to ensure that the gradual resolution of the genital ulcer is happen, which can be expected to heal within 2 weeks after initiation of treatment, unless it's unusually large. Now we will take the herpes infections caused by DNA virus, herpes simplex infection type 2, which is genital herpes. But so we have type 1 also, which is the oral herpes simplex, but it can also cause genital infection, but it's less common than type 2, which is genital herpes. The presentation, incubation period about 21 days. The first attack is the most severe one with pain, vulvitis, ulceration, lymphadenopathy, and discharge. It resolves after 3 to 4 weeks, but may cause secondary sacral radiculomyelopathy or meningitis. Recurrence can be triggered by stress, sex, or menstruation, but subsequent attacks are normally shorter and less severe than the first one, than the primary infection. Diagnosis is by culture of serum collected from the vesicles by aspiration or by sweeping at the base of the ulcer. Serum anti-herpes simplex antibody level are increased. Treatment of choice is acyclovir. Condoms should be used unless both partners have history of herpes. This picture show you the difference between the ulceration between chancroid, which is in figure A, herpes infection, which is in figure B, and syphilis ulcer in figure C. Gonorrhea, which is caused by Neisseria gonorrhea, which is intracellular gram-negative diplococci that grows in columnar epithelium. Incubation period about 2 to 5 days. 50% of women are asymptomatic, but 15% can present with acute onset of pelvic inflammatory disease with abdominal, lower abdominal pain, and associated with vaginal bleeding. It may also cause partheninitis, vaginal discharge, perihepatitis, septicemia, arthritis, rash. So keep in your mind again that the patient may come with the complication of the infection, not with the infection itself, not with the symptoms of infection itself, but with the complication of the infection. The diagnosis is by presence of intracellular gram-negative diplococci by gram stain, preparation from cervical or urethral or rectal swab. You can take swab from one of these sites, which can be infected by gonorrhea. The treatment is by dual treatment, third generation cephalosporin with plus azithromycin. Contact tracing and the treatment of partner is essential prior to the resuming intercourse. Confirmation of a cure should be obtained by 2 sets of cultures following the treatment. Now we take Chlamydia, classified as virus in the beginning, but it is a bacteria. It's a gram-negative bacteria, obligate intracellular parasite, non-motile, non-spore forming, a most common bacteria that cause sexual transmitted diseases. It's of 4 species, as you see in the slide, and it's of 3 serotypes. A to C that cause conjunctiva, that infect conjunctiva and cause trachoma, D to K that infect the genitourinary system, and L1 to L3 which cause lymphogranuloma venorum. The presentation of it is vaginal discharge because of cervicitis, urethritis, cause symptoms of pelvic inflammatory diseases, perihepatitis, which is the complication of pelvic inflammatory disease, which is called Fitz-Hugh-Curtis syndrome, as we said before, or Reiter syndrome, which is consists of arthropathy, rash, and conjunctivitis. And keep in your mind again that the patient can come with these complications. 80% of women can be asymptomatic. The diagnosis is by culture. There is a specific culture for chlamydia, or we can diagnose by ELISA detection of antigen obtained by swab. We take it from endocervix. Perihepatic adhesions, we can see it if we do laparoscopy for diagnosis. Treatments, if the patient is untreated, there will be significant complication, the tubal damage and subsequent infertility, of course. Treatment of choice is doxycycline with the full dose, which is avoided when the patient is pregnant. We can use, instead of it, erythromycin. And we use with it erythromycin, and we use also azithromycin 1 gram, effective as a single dose. And repeated swabs must be done to confirm the cure after treatment. Now we take the other type, which is parasite, protozoal, Trichomonas vaginalis, that cause trachomas. The presentation is a mucopurulent yellow sugarinis. This is characteristic discharge. So yellow sugarinis, offensive vaginal discharge associated with vulvovaginitis. And if we examine the cervix, not always, but in many cases, we see this type of cervix. It's called strawberry cervix because of the presence of punctated hemorrhage in the cervix. Look like this. The diagnosis is by seeing flagellated organisms on wet slide preparations. A flagellated organism has 4 flagella in its body, as you see in this picture. Treatment of choice for Trichomonas vaginalis is metronidazole, flagyl, high dose, single dose, 2 gram. That's to say 500 milligram tablet, 4 tablets at the same time. Or the normal regime, which is 400 milligram twice daily, 7 days. For pregnant, we can use 200 milligram 3 times daily, also 7 days. Partner must be treated. The last infection, which is sexual transmitted diseases, is HIV infection. It is estimated that almost 40 to 50% of individuals with HIV infection are women. Intravenous drug use, heterosexual transmission are responsible for most of cases. For AIDS, infection with HIV produce a spectrum of disease that progress to form asymptomatic state of full-blown of AIDS disease. The median time between infection with HIV and development of AIDS is a long time, about 10 years, and it's between few months to 12 years. The natural history of disease can be significantly altered by antiretroviral therapy. Women with HIV-induced altered immune function are at increased risk of infections like tuberculosis and other atypical type of pneumonia like pneumocystic carinii pneumonia. Because of its impact on the immune system, HIV can affect the diagnosis, evaluation, and treatment and follow-up of other sexually transmitted diseases because it will decrease the efficacy of antimicrobial therapy for treatment of other sexually transmitted diseases. How can we diagnose HIV? By HIV type 1 antibody test or by ELISA or rapid assay. If confirmed by Western blot or other supplemental testing, positive antibody test results confirm that a person is infected with HIV and capable of transmitting the virus to the others. So HIV antibody is detectable in more than 95% of patients within 6 months of the infection. Women diagnosed with any sexual transmitted disease, particularly genital ulcer disease, should be offered HIV testing. And women at high risk of sexual transmitted diseases, such as multiple sexual partners or have multiple sexual partners or drug abuser, should offer testing for HIV testing. The initial evaluation of HIV positive women includes screening of disease associated with HIV, such as TB, sexual transmitted disease, administration of recommended vaccines like hepatitis B, pneumococcal, influenza, and even they need psychosocial counseling. Intraepithelial neoplasia is strongly associated with human papillomavirus infection, and it has been found that occur high frequency with women with HIV. That's to say, infection with human papillomavirus seems to be more with patients with HIV infection. What is the treatment for HIV infection? Decision regarding the initiation of antiretroviral therapy should be guided by monitoring the laboratory parameters of HIV RNA, that's to say viral load, and the CD40 cell count, and also the clinical condition of the patient. The primary goal of antiviral retroviral therapy is to suppression of viral load, restoration and preservation of immunological function of the patient, improvement quality of life, and reduction of HIV-related morbidity and mortality. So the treatment should be offered to those women with fewer than 350 CD40 cells or plasma HIV RNA levels exceeding, that's to say viral load, exceeding 100,000 copies. Patient must be willing to accept this therapy to avoid the emergence of resistance caused by poor compliance. In addition, patient with less than 200 CD40 cells should receive prophylaxis against opportunistic infections such as trimethoprim, sulfamethoxazole, or aerosol pentamidine, especially against the atypical pneumonia, which is called pneumocystic carinii pneumonia. This was the last slide. Thank you very much for your attention and good luck.